some of their success, challenges, and resource needs. I know this is an area of focus for many of our partners across the state, community-based organizations, hospitals, and ambulatory practices as well. So we are really thrilled to have this amazing panel here today. I'm first going to introduce you all to our moderator. Our moderator is Rebecca Alderfer. And Rebecca is a seasoned strategist charged with evaluating the capacity of healthcare workforce in Colorado at the Colorado Health Institute and expanding mental health screening and access to care during pregnancy and postpartum period for the Zoma Foundation. Rebecca earned a Bachelor of Science degree in economics from Iowa State University and a master's degree in public policy from the Humphrey School of Public Affairs at the University of Minnesota. She is the mother of 2 boys, enjoys competing in triathlons and running, and is full of wanderlust and always planning her next adventure. Rebecca is a trusted partner, not only providing financial support through Zoma Foundation to the Maternal Mental Health Collaborative and Framework and CPCQC's efforts, but also providing a really strong partnership and really centering the work. And so I consider Rebecca a trusted colleague and friend. And so we are just thrilled and fortunate to have Rebecca here as our moderator for today's panel. With that, I will pass it off to you, Rebecca.
Wow, perfect. Thank you. Good afternoon, everyone. I am so excited and energized to be here with you and to have the opportunity to moderate this panel, primarily because it is dedicated to the most common complication in pregnancy and postpartum. And that most common complication is perinatal mood and anxiety conditions and substance use disorder. There's been a few stats that have stuck with me over this past year as I think about this issue. Many of them are highlighted in the data that Healthy Moms is collecting through the Maternal Mortality Review Commission of Colorado, and also the new Medicaid report that just came out last week on maternity care in Colorado for those that are on the Health First Colorado plan. And those 3 stats that I want to share with us just to set the scene and then turn it over to our panelists is that suicide and overdose are the leading causes of maternal mortality in Colorado. The universal screening isn't there yet. We're getting there in prenatal and postpartum one-time screens, but when you look across the perinatal period, it really falls off. I think the Medicaid report said they could account for about 35% of their pregnant women being screened, mothers being screened, either prenatally or postpartum. But the continuum of care is growing. We are seeing peer support specialists all the way through reproductive psychiatry consultation programs getting a foothold in this state, and there's just so much energy and momentum. This panel that we're going to introduce is saying we must do better and we can do better, and they're actually paving the way across all of their systems and transforming the kinds of care that they're offering to women and their families throughout the perinatal period. So with that, I'm just thrilled to have you all with us. And I'm going to turn it over to Heather Hagensen to talk about the work that she's doing at SCL Health. I'm going to give a really short intro, Heather, before you get to talk. And then each of the panelists is going to give 3 to 4 minutes of what their system is all about, what they're doing around perinatal mental health, and some unique components. And then we'll dig into the really tough questions. No softballs this afternoon, guys, even though it's Friday afternoon. So Heather Hagensen currently serves as the Director of Operations and Business Development for the Birth Center of Denver, Bloom Perinatal Behavioral Health Program, and the Center for Women and Infants at St. Joseph Hospital, where she provides administrative and operational support for selected programs in order to ensure the strategic growth and development. From 2004 to 2014, Heather served as a member of the Colorado Perinatal Care Council. So Heather, kick us off. Tell us what you're doing at SCL.
All right, thanks, Rebecca. I'm so excited to be here today to share the work that we've been doing. So SCL Health really, our perinatal behavioral health project was focused on our 4 hospitals in the Denver metro area, which are St. Joe's, Lutheran, Platte Valley, and Good Sam, as well as our associated about 12 OB employed clinics. We deliver about 9,000 babies at the Front Range hospitals in our SEL health system. And so I think we recognize that this broad reach presented an opportunity for us to demonstrate how a large, and the key word is open, healthcare system could implement an integrated OB evidence-based continuum of perinatal behavioral health services. So the project's location within an open health system really was particularly important to us because we have partnerships with a variety of employed, private practice community physicians, and we work with a number of health insurance providers, including the large Kaiser network. So building a program in an environment where different entities don't report to the same leadership, where different entities may have conflicting ideas about program implementation is really more difficult than a program in a closed system where one organization kind of oversees each component of a continuum. So when we began this project and we did a needs and barriers assessment, we really were looking, we identified that there was a very limited amount of behavioral health services, no standardized protocols or training opportunities at all. And our OB providers often felt like if they screened patients and identified emotional complications or vulnerable patients, that they really didn't have the time or the resources to close the gaps in care for them. So thanks to a very generous grant from Zomo, our project unfolded over the course of 3 years. And so during that first year, we had a project coordinator, a project manager. We established a project advisory committee really to help frame and implement the work that we wanted to do in the second year of our project. So what we did in that work is we developed universal screening during and after pregnancy using one consistent screening tool, the EPDS, at key intervals starting at the very first prenatal appointment all the way through their postpartum care. We also developed score-based response protocols, regardless if it was in the inpatient or outpatient setting. So there was a lot of consistency there. And then we identified further assessment, treatment, and referral interventions. We created an e-learning module before we ever started any of this work that over 500 of our employees and physicians really went through so we could create a really solid foundation of similar language, similar information and tools and resources. We sent quite a few people through the PSI certificate training so we could develop subject matter experts to help champion the goals of the work that we were trying to do. And then we implemented our first pilot program. And so that was in the second year, and we developed it at St. Joe's first, expanded it into Lutheran, and the 9 clinics associated with those sites that were midwifery, maternal fetal medicine, and OBGYN. During the third year then, we expanded it into Platte Valley and Good Sam and their associated clinics. And then we developed a pilot program in our NICU, as well as in our high-risk antepartum units. So really, and our lactation and outpatient settings. So I think a large part of our success of our program in this open healthcare system was really due in large part to one size does not fit all. We really said, this is the standard, this is what we want to implement. So how does that fit into your specific inpatient unit or clinic? And this was really due in large part to a very committed senior leadership, women's leadership, and all the champions in each area that really helped work with people. So it didn't feel like we were shoving another initiative or anything down anybody's throat, but really that we were working with them and collaborating with them and honoring and respecting how each unit was unique. So our Bloom program consists of licensed social workers, professional counselors, a registered dietitian, a bilingual case manager. We have varied experience in perinatal mental health, infant mental health, NICU, birth trauma, palliative care, and perinatal bereavement. We do in-visit assessments, case consultation, individual counseling and support, medication therapy in consultation with the prescriber, case management services, nutrition counseling, support groups. So we really have a lot of variety to support our families, wherever they're at in their journey. So our maternal mental health project that was initiated in 2007 is now called our SEL Health Bloom Perinatal Behavioral Health Program. We selected the word bloom for the program's name for a reason. Blooming flowers, signify growth, beauty, color, diversity. Flowers need time and the right mix of resources to grow, and we know that so do our patients and families. So we really were intentional in the naming of it to reduce some of those stigmas associated with it. So I will just end on, I am so proud to report that our Bloom program screened nearly 9,000 women across all of our program locations in 2020, planting seeds for well-beings for our families. So thanks, Rebecca.
Oh, thank you, Heather. Wow. That was 3 to 4 really packed moments, and so much in there that we'll have to unpack later. And so thank you, Heather, for doing that. Next, I'm going to introduce Dr. Blake Mclaughlin. I hope I'm going to do your bio justice, Dr. McLaughlin, but finished residency training in obstetrics and gynecology at the University of California in 2007, and went on to spend a significant amount of time at the University of Colorado working with the Children's Hospital to create and develop the Maternal Fetal Care Unit's OB Hospitalist program. And now, as of July 2020, you picked a really good time to start your new role in the middle of a pandemic. He is with Banner Medical Group as the Medical Director for Women's Health Services and Generalist OBGYN at Sterling Regional Medical Center in Northeast Colorado. Dr. McLaughlin shares the engaging whole person focused patient care, one interaction at a time, and creating life-giving organizational cultures and leading healthcare transformation strategies is his passion and professional goal. Thank you so much, Dr. McLaughlin.
Absolutely. Thank you. Happy to be here. I think what I would share about what's happened for us with Banner and Sterling specifically is, when I came to Banner and Sterling about a little over a year ago, there were excellent processes already in place in terms of screening all of our patient population for mood disorders, for anxiety and depression. And so we were really good at doing that. There was definitely an opportunity then, as we partnered fully with CPCQC, to take on the AIM initiative for this year for universal screening for substance use disorder. And so, while as a team we were completely in and completely committed, what I personally really realized, and I think a lot of my team members realized, is, these areas of mental health and substance use disorders aren't our primary focus as OBGYNs or family medicine providers with an OB focus. And it feels intimidating. It feels overwhelming because, the things that we're used to in terms of women's health typically fall into the traditional things that are thought of with obstetrics and gynecology care. But clearly the data speaks for itself, and the stories speak very loudly in that what is needed right now is the attention that we're giving to mental health and substance use disorder. And so in the midst of that overwhelm, the first thing was for me and for us to just take a deep breath and acknowledge this is totally overwhelming. What the heck do we do? And also to realize we don't have to reinvent the wheel. And so in really leveraging our partnership with CPCQC, what happened is we were able to network deeply and closely with these incredible organizations throughout the state, throughout the region, and even locally that were already doing the good work. And so what was really cool that has come out of that is we did a perinatal mental health open house back in March, and it was really cool. Some of the folks here on the panel attended that and represented their organizations and the work that we're doing. And what that did is it made it personable, right? So instead of it's just this organization that I'm going to, give the patient a handout to and hope that they call. I've literally had patients sit in my office that, is decompensating, life is spiraling out of control. And I've been able to call on the phone some of the folks here and say, hey, can you take time? And they've said, yes, absolutely. Let's get them on the phone right now and we'll troubleshoot this. And as somebody who doesn't routinely prescribe, medicines for mental health that are more technical, I was able to work with a psychiatrist at another institution, and she was able to tell me, hey, let's get her started on this and this, and this will be the follow-up plan. So out of that perinatal mental health open house, we've developed about 10 really robust, solid relationships with folks across the state doing great work. And we just continue to build those relationships and expand, sort of that bandwidth and that stream of helping to connect our patients. And so it's been really powerful, and it's taken that intimidation factor down, incredibly, to feel like, okay, I can call a friend, phone a friend, I can get help when I need it. And I would say that's been an incredible, shift for us where we're at in Sterling and regionally as well.
Thank you so much, Dr. McLaughlin. We're going to dig more into community partnerships as we have our conversation. So great that that's all teed up. The next two, I'm going to introduce them together, and then I think Jen's going to give the overview. But we have Jennifer Hardin Adams and Jill Olman, who both work with Health One. I'll introduce Jill first and then Jen. So Jill Olman is a licensed professional counselor and nationally certified counselor specializing in perinatal mood and anxiety disorders. Jill works with clients throughout pregnancy, infertility, pregnancy loss, pregnancy anxiety, and navigating the postpartum period. She also facilitates a variety of virtual support groups. Jill is currently the integrated care coordinator for many Health One hospital facilities working on perinatal mental health integration. Jill works in partnership with OBGYN offices at Rose Medical Center and Skyridge Medical Center, offering therapy, resources, and psychiatric referrals to patients, both prenatally and postpartum. And Dr. Jennifer Hardin Adams is a clinical psychologist with a specialty in women's reproductive health and a special interest in supporting healthcare providers around compassion, fatigue, and burnout. She currently works at the Center for Maternal Fetal Health at Rocky Mountain Hospital for Children at Presbyterian St. Luke's Hospital in Denver, where she provides services to mothers on long-term hospitalized bed rest, families in the NICU, and to expectant families anticipating a NICU stay or who have other special needs. Jen also serves as the president for the Colorado chapter of Postpartum Support International. Jen, Jill, I'll let you share an overview of Health One's programs.
I'll start. Thanks, Jen. Thank you, Rebecca and Jamie and everyone. It's just such a treat to be here. Thanks so much for having us. So as Rebecca mentioned, through the partnership with Zoma Foundation, I have been in OBGYN clinics as essentially the in-house therapist, integrated care coordinator for the last 3.5 years. What started specifically at Rose at both Midtown and Metropolitan OBGYN has recently in the last 4 or 5 months expanded down to Esprit and Women's Care OBGYNs down at Skyridge. And so we I and my colleagues are in the clinics, and we are able to offer 5 free 30-minute therapy sessions to every patient of all 4 of those practices. So similarly to what Heather was mentioning, we do a PHQ-9 screen at that first check that we get to see them prenatally, and then we repeat postpartum. So our time with patients runs the gamut from their entire pregnancy up through 1 year postpartum, and then we are able to offer support and help in resources, finding individual therapists that accept their insurance, finding support groups, books, connections, podcasts. So we've been really, really fortunate to, over the last 3.5 years, we've been able to see over 1,700 pregnant people, at least one time unique individuals, and many of those 2 to 5 times to support them through their pregnancy, through, again, the pregnancy and postpartum periods. We've been very fortunate at Health One to be able to collaborate across the board, and Jen was already doing such great work at PSL. So then to be able to expand at Rose and Skyridge, and then very fortunately, we have a wonderful referral source in our new women's unit that just opened right at the start of COVID over at the Behavioral Health and Wellness Center in Aurora. And so have a direct line for psychiatric referrals and assessments there. So it's been an amazing opportunity for collaboration and growing and supporting women. And fortunately through COVID have been able to continue to provide these services through telehealth. So women who are postpartum and can't leave the house or don't want to leave the house, or pregnancy anxiety and, don't need to worry about childcare. So we've been incredibly fortunate that the program has continued and grown exponentially through the COVID season.
and like Jill said, so glad to be here. I'm Jen Adams, and I'm a psychologist over at PSL and Rocky Mountain Hospital for Children, where I'm in the Center for Maternal Fetal Health. For those of you who aren't familiar with the center represents a partnership between high-risk MFM practice and the Nicu practice over at Rocky Mountain Hospital for Children. And we work to provide services for families as they learn of complications or medical diagnoses for their babies during pregnancy, and provide navigation support for them throughout their process, both prenatally in the NICU and then post-discharge, and then going on forward should the child have additional medical complications. So that's a wonderful program. Within the program, there are our team of navigators who are also located at Rose and Skyridge as well, because we sort of work together as a larger hospital system, and our 2 genetics counselors who provide that education and support to families. And then I'm there in my role, sort of in that emotional support role for families prenatally, if they're with us for extended hospitalized bed rest, and in the NICU. Another program that I just sort of like to highlight too is, we do try to do as much preparation and education for families in advance before they start to, just as they're starting their journey. One of our favorite things is our Nicu Prep class that we do for the families to help them anticipate and learn about the NICU before they get into that experience. And it gives them an opportunity to connect with other families who are expecting their babies around the same time, as well as connecting them with sort of parent mentors who come back and serve on a parent panel and as an informal parent resource for them as they're on their NICU journey. So that's a little bit about us at PSL and Center for Maternal Fetal Health. But as Rebecca mentioned, I also serve as the president of our Colorado chapter of Postpartum Support International. So I'll sort of be wearing 2 hats as we go through some of these questions today, to talk about sort of those community opportunities for partnership and training and workforce development, and how community support organizations, help support our families here in Colorado. So thank you.
Wonderful. Thank you, Jen, and thank you, Jill. We have so much to talk about, especially about how you coordinate with the new inpatient opportunities that are available across Health One as well. I'm going to then turn over to Callan Thornton. Callan Thornton is the manager of Gender Responsive Services at the Colorado Department of Human Services Office of Behavioral Health. Wow, that is a long sentence, but she is the senior staff authority on gender responsive behavioral health treatment and on substance abuse treatment for pregnant and parenting women. Within her role, Callan has primary responsibility for gender responsive statewide programs and works collaboratively across sectors to develop programs, policies, and best practice guidelines that enhance Colorado's gender responsive continuum of care. So glad to have you on the panel, Callan. Tell us about the work that you're doing.
Absolutely. Thank you so much. It's like Jill said, such a treat to get to be here with you all. So I have the great privilege of working for the Office of Behavioral Health and, have a foot or a toe in a lot of the different maternal behavioral health initiatives that are going on across the state. A couple of those that I am most excited to share with this group today are the Special Connections programs in Colorado. So I programmatically oversee Special Connections. And what that is residential substance use disorder treatment for pregnant and postpartum individuals who have need of residential level of care for a substance use disorder. What's so amazing about the Special Connections programs is that moms don't have to choose between pursuing recovery and parenting. They can do both at the same time. So Special Connections is for pregnant women. Many women in that program give birth during their stay, and their infants and other young children are able to stay with them at treatment as they're working on recovery related stuff and building parenting capacity. We have 6 of those programs in the state right now, with a 7th that is set to open before January. So that has almost doubled in the last 2 years, which is really exciting. There's still a huge need for expansion across the state of those programs, but we are making progress. Another program I would love to tell you about, it's actually a public awareness campaign, and it's called Tough as a Mother. And so that is our state's public awareness campaign that really has two purposes. The first being to decrease stigma around maternal substance use disorder, because stigma remains one of the greatest barriers to moms seeking treatment. And then secondly, and equally as important, helping to connect pregnant and parenting moms to treatment resources and supports in their communities. So September is actually National Recovery Month, and we are in the midst of a micro campaign right now called Recovering Out Loud with Tough as a Mother. And we have had these just brilliant, courageous moms from across the state film their stories and send them in to us. And the whole idea is recovering loudly so that other moms don't have to struggle in silence. And so you'll find some of those resources in the virtual resource sharing for this conference. But that has just been such an honor and privilege to get to work on that campaign. And we're continuing to grow and develop Tough as a Mother support groups. And, just want to acknowledge that on the best of days, mothering and parenting is tough, and it's all the much harder when a substance use disorder is in the picture. But we really speak to women to say, you know what, motherhood is tough, addiction is tough, but you're even tougher. I also want to quickly mention the Integrated Care for Women and Babies programs. That's called the shorthand ICWB through University of Colorado. And that is something that was put into legislation a couple years ago. And the high level is that we're bringing substance use disorder treatment services into OBGYN settings and bringing OB services into substance use disorder treatment settings. So just trying to bridge those two worlds to bring whatever care pregnant and parenting folks need to wherever they're at. So that was actually just made into a permanent program this summer. So that's also a big celebration for the state. Oh, thanks. I saw Katie pop Tough as a Mother in the chat. Then the last thing I'll mention is just kind of a cool, innovative thing that we've been working on are the mobile childcare units. So the state has been working with the Office of Early Childhood and Illuminate Colorado to purchase and renovate RV units into childcare, like little daycare mobile units. And those mobile units are driving up and parking in some parking lots of treatment centers, and so that parents are able to drop their kids off in safe childcare while they're going to participate in their treatment. So we have 2 of those mobile RVs that are out serving families right now, and a third one that is funded and going to be built. So I'll stop there, but those are a couple of exciting things that I get to do in my job that benefit folks all over Colorado.
Thank you, Callan. And I have seen the onesies that say Tough as My Mother, and they are absolutely adorable. So definitely check out that campaign and all that's going into it. There's also a CDPHE awareness campaign around perinatal mood and anxiety disorders, which is great as well. So I promised you I wasn't going to hold any punches on a Friday afternoon. So we'll start with the toughest one. We hear over and over again, I think the refrain is still pretty common, I would screen, but. So how do we get at that? Are we making progress, and what do we need to do more of? And I'm gonna make Heather the first person to maybe address that. And then Jen, if you have some thoughts on that too, we'll flip to you.
So I think when we started our program, that was definitely something that we heard. I would screen, but there aren't resources. I would screen, but what does that mean if I don't have any place to send, our patients to? And I think for us, that was really important that we listened to what they were saying and really dug into a needs assessment to figure out what services do we have internally, what services do we have externally. We talk about partnerships in the community and really building that out. And what we could support before we even implemented a program was really key. And I think one of the things that we did at SCL that is we did a complete culture shift. And so when you think about screening and the universal screening in the inpatient and outpatient settings, I think when they see that there's value and that they see that there's resources out there to support the women, then I think you continue to, then you break down the barriers of saying, I would screen, but. And some of it is building up the trust that when you say, we'll have the resources for you, and or if we don't, we'll figure it out, so that you continue to screen and we don't hear the, I would screen, but. Because I really think that when you build a foundation and you build a culture of supporting women and their families, I think it creates, it takes down the barriers of that universal screening. And I think when we're all working towards the same thing together, I think it doesn't feel like you're in isolation when you're screening and you're trying to figure this out, but you have a larger collective team when you integrate behavioral health into the OB setting to say, you don't have the resources to figure it out, but let our behavioral health team figure it out for you, or let our navigators figure it out for you. And I think that when you build that into a culture change, then the mindset shifts and then you break down that barrier, I would screen, but.
Jen, how do you respond to that as well? And then if any other panelists want to jump in, you're more than welcome.
Yeah, no, I think that that's such an important thing, that trust between, the patient and the care provider, and also with the care provider with what the resources are that are available to them, whether it's within their system or out in the community. With PSI, our aim is to provide direct peer support to families through our, phone and text lines and online support groups, and also to provide training and workforce development for healthcare providers so they can provide informed services to moms and families during pregnancy and postpartum, and to also try to bridge that gap that Heather was talking about, kind of bridge the gap between the providers on the behavioral health side and the families together. And we're doing that, through our, expanded online supports, which, one of the few good things to come out of COVID, as well as, through our PSI directory, which is available to anyone free of charge. It's also available to healthcare providers to list themselves as perinatally informed behavioral health or other allied, providers like lactation consultants and those folks as well. And I'll drop those links in the chat as well. But yeah, just having, trying to take away, the resources are out there and available. During the NICU talk earlier today, that, it was discussed about how there are really quite a few resources here in Colorado, but sometimes we get into our silos and have trouble remembering, what's outside of our system or what's out in the community if we're part of a system. And so PSI does, definitely hope to raise that awareness of how we can help providers connect their families to support in the community.
Anybody else want to jump in on the how do we get past the I would screen but question?
I'll jump in there quickly, Rebecca, and just say that, as somebody that used to work in a hospital setting, and as a person that's married to a physician, I can say that, when I'm talking to my partner about, you really should be screening for intimate partner violence in these pediatric visits as well. And his response is like, do you have any idea how, like in these 10-minute visits, how much is put on my plate? And so I do think that there's this hot potato issue of, it's the provider's responsibility to screen for, maternal behavioral health stuff, whether that's mental health or substance use disorders. And that there is so much on providers' plates, and then it's like, oh, well, the nurses should be doing that, the medical assistants should be doing that, and there may be even more on fire sometimes than the physicians are. So I'm just such a huge fan of looking for a third way and looking for ways, which I feel like CPCQC is doing a great job of leading some of these conversations about bringing a third entity into these traditional settings to be able to do relational screening in a way that isn't so machine-like and fast, and to take some of the pressure off of some of the medical folks. And I would just say that there's all sorts of neat grants all the time at the state level to do some of these innovative things in healthcare settings. And so I would just encourage folks at this conference to reach out to the panelists, reach out to me, and we can help connect you with different types of funding opportunities and to get creative about the third way or a different way of screening and successful referrals.
That's fantastic, Helen. Thank you so much for that. Time is really one of those things that we hear a lot. And so if the healthcare setting is overwhelmed or doesn't have the resources internally, where do community organizations fit in? And Dr. McLaughlin, you touched on this. I wonder if you can go a little deeper. One of the conversations that we have in perinatal mental health is, what lives within a hospital setting or a healthcare setting, and what is sort of lives in the community, and how do those two connect? How do you connect the dots? And so if you'd like to start and talk about community versus healthcare and how to bridge those gaps, and then we can open it up to others as well.
Happy to address that. And maybe I'll start by just backtracking a slight bit to the previous question. For me, as the emphasis was coming online for this is our AIM initiative for 2021 for CPCQC and addressing universal screening, substance use disorder, and mental health, I really had to pause and think, and ask just a very pragmatic question: is this worth my time? And it is, and I really discovered it is as I sat with that question, because for me personally, and many of us in healthcare, and particularly in obstetrics and gynecology, there is this element of, we get satisfaction from quickly intervening and resolving a problem, right? So if there's a postpartum hemorrhage and we can sort of sweep in and save the day, and there's this, hero ego thing that gets stoked, that's very gratifying. But when we really, pause and step back and think about it, is that going to, dramatically shift or alter the trajectory of that pregnant person's life and their family and the kids and generations to come? Perhaps very rarely, intervening early for a postpartum hemorrhage would, or preeclampsia, these things that we, traditionally think about. But what really grasped me and I come back to and am reminded of, even in this panelist conversation, is when we can step in and we can align with someone's journey of transformation in terms of their mental health and disordered relationships with substances, which, as we know, most often comes out of the trauma that's in their story. And in our stories, it's an us conversation, not a them conversation. The trauma that comes from our stories, when we begin to engage those things, we begin to alter the trajectory of people's lives and their children's lives, and it becomes a generational thing, a legacy impact. And I think for me, that's what has really shifted some of my energy. Yes, we're going to address preeclampsia. Yes, we're going to address postpartum hemorrhage. We are going to do the things that are that we need to do and have to, and are obligated to do in terms of safe, quality care. But there's this added bonus and this value added thing where we can begin to impact and affect people's lives. That's going to be a generational thing. And so that's what gets me excited. I get stoked up when I talk about it and energized. And so then it becomes, yes, it's not the, I would screen, but it's like, I really have to, if I am going to have the sense of, authenticity and integrity in what I've committed to my life to professionally, it's worth it. And at the same time, being gentle and kind with ourselves it's intimidating to do that, right? And so that's where I think this question comes in, Rebecca, that, I don't have to go back to medical school or go through residency and become a psychologist or a psychiatrist or a mental health therapist. I don't have to do that. I can just make the connections with people that are excellent at it. And so in the same ways that I think about, I'm not an expert in renal disease. So if I have a problem that's outside of my scope of care, I call the nephrologist and I get help. And so I don't have to be an expert or the problem solver in the social issues that are surfacing, the mental health issues that are surfacing, the substance use disorder issues that are surfacing. I can call the good people at LifeStance and say, hey, can I connect this person with you? Here's a warm handoff, with this patient. Here's her name, here's her story, and then let's circle back, in the next week or two and find out how that's going. Or if there's disordered substance use and there's an addiction to opioids, that I can connect with Front Range Clinic, and they can get in for their initial intake visit on Tuesday morning in Sterling, where they have the pop-up clinic. So I don't have to reinvent the wheel. It's just a matter of partnering and making relationships. And I think CPCQC is this hub, this clearinghouse, this place where any provider in the community, whether it's in a urban metro setting or out in the rural frontier locations, where we can connect and get to the right people that we need to get our patients to, and have the support that needs to happen. And it's intimidating. It is initially, but it can be done. And it's a matter of it's this networking thing that in medicine we're not real great at. The business world and a lot of other places are good at networking, but in medicine there's this opportunity to do it, especially with the explosion of telehealth and Zoom conferences that we're doing. We can make this happen. And so it is a matter of, I think, reaching out to a wise helper, and CPCQC can really function as that clearinghouse for those relationships.
Perfect. Thank you so much. I wrote it down and put quotes around it. Is it worth my time? And I think maybe that'll be the quote that comes out of this session, that yes, it is worth the time. Is everyone else hearing that echo?
Yes,
Okay.
we're gonna hopefully take care of that really quickly.
Okay, perfect. I don't know if it's me. Oh, there. I think we're back on track. Perfect. Thank you so much. We'll come back to the community connections, because I think folks will have a question about, does that mean that everyone has to create their own Google spreadsheet? Google spreadsheets go out of date. So we know that there are better, more efficient economies of scale on some of this stuff that we can talk about as well. I want to flip it over to Jill and Jennifer as well, to talk about the challenges that you've navigated in trying to integrate perinatal mental health care across a system, or even within a system. There are others on this panel that can answer that question too. But one of the things that we hear all the time is, that sounds great, but how do you pay for it, right? And how do you sustain it? And what are the EMR challenges and others? So can you talk a little about what you continue to face and maybe some ways to address that?
Sure, I'll go ahead and start with that. Yeah, I mean, that's exactly what we do here. As I mentioned, our program that I talked about, that I run, is Zoma funded. And I remember walking into my OBGYN offices the first day and saying, okay, my goal is, how do we get the hospital to buy in from day one? And so that's always been my goal. And I think we're very, very fortunate to have partnerships. Like I mentioned, Jen was already doing such great work at PSL. This is not reinventing the wheel. This is already something that has been in place. The vision has been there. We are beyond lucky to have our CEO at Behavioral Health, Cindy Myers, who is all in. And in fairness too, once the providers at the OBGYN clinics are seeing what's working, they're all in as well. You can't take this away once it's established. No one wants to go backwards. So I think the proof is in the pudding to an extent. The success speaks for itself. And so, yeah, I think, obviously funding has its own challenges and has its own kind of discussions behind, forward for us, and even kind of behind the scenes. But it absolutely is something that I think the buy-in is there. I know Health One has always wanted to be, the safest place in America to deliver a baby, and that includes that 1 year postpartum. And so we've been very fortunate to have, the support of both our continental division and the head people down in Nashville. But so yeah, it's a program that I think, to your point, Rebecca, that yeah, there's funding at play, obviously, but the good news is that there are, again, with our partnership, even with the behavioral health hospital, and with joining on with, I think, Cindy has ideas for, sorry, what's the word I'm looking for? Kind of almost like leasing out employees and whatnot. I just think that the expansion is there, the framework is set up, and again, once patients and doctors both experience the amazingness of this program, it kind of speaks for itself.
I agree with a lot of those points that Jill made. I think that regardless of where the funding comes from to support these behavioral health programs, having champions within your system is really the key. And, you need a champion to help you get in the door. And then you also need champions to help you grow and gain credibility amongst, the partners that you have in your setting, which then can lead to, more opportunities and greater growth of any programs that you want to move forth. So Heather, I'm sure you've seen that, at within your system as well, just that need to have those champions kind of throughout at all those different levels. And as we were talking, through this and with Dr. McLaughlin and the things he was sharing is, I was struck by sort of the parallels between, needing to create that safety net for the families that we serve, but then kind of creating that safety net and networking and I guess net is really the, what web, I guess, for the providers is we're working to, collaborate and not have to reinvent the wheel and do everything by ourselves. But then we also sort of need that at the systems level. And I feel like, we're really lucky here as a state here in Colorado, because we are starting to shift into that deeper systems level and how can we work within institutions within our own systems, but also work across systems and across systems and community to kind of bring it all together in a tighter web to support everybody all the way up.
Thank you so much, Jen. And Heather, I was going to hope you were going to jump on that as well and talk a little bit about the value proposition, how you raise up the value proposition of really transforming perinatal mental health care in a system.
Yeah, I think, it's as Jen said, it's one of those things that you have to have support and champions at all levels, whether it be your clinic medical assistants, the nurses, the senior leadership teams, the CEOs, the corporate teams. And I think to see the value proposition, right, is in the outcomes that we have for the women and the families and the numbers. As I shared earlier, we screened a lot of women, and when you see the sheer volume of the impact that you have on that program, I think it does bring value. And I think that there's so much collaboration that goes on, like you said, within your own system and with other systems. I think we have to, this mental health crisis that we're in really breaks down barriers of competition and encourages collaboration amongst all of our healthcare systems, because we all have different specialties that we rely on and refer to each other. And I think that just expands, into our community and resources. I think from a value proposition standpoint, I think there's so many different ways, as you talked about with funding, right? There's definitely complex challenges with getting billing and reimbursement and all of these across all these healthcare systems. But I think there's also other ways to bring value. There's so many value-based payment initiatives that we're looking at SCL Health with the hospital transformation program and the HQIT measures, and how do you align your organization and your program to those measures to support those initiatives. And that alone, it may not bring the financial funding value in the same way that you would traditionally, where you bill a code and you get reimbursed for it, but it brings value to the program overall. In a nonprofit healthcare setting that we're in, we have a lot of community benefit for the services that we can provide as well. So I think, when you start looking at it, not just in your little niche of the world, whether it's in your clinic or your hospital, but you really elevate it to a more of a system level and see how the system can cross-cut through all of those, is one of the ways that we've really found has brought value to the program, without necessarily the direct funding that is a challenge for all of us to always find, and just having those innovative, supportive ways.
Oh, thank you so much, Heather. I know we're going to run out of time before we get to all of the questions that this panel is going to address. So just a teaser, we had about about 15 more topics to cover on this panel. So anyone who wants to dive deeper, we can figure out a different roundtable sometime. Callan, I want to get you in here though before we open it up to Q&A. Can you talk about what's shifting around substance use disorders and pregnancy and perinatal mental health that's maybe making it easier to access, to look at screening? What are some things that you think are really going to drive change over the next couple of years?
That's a great question, Rebecca. I think there's so many really neat initiatives going on in that space. I think, as the panel has mentioned, just this, push toward universal screening. It's simple, but kind of that idea around you can't solve a problem that you're not willing to have. And I think for so long in many healthcare spaces, maternal substance use disorder is a problem that healthcare system has not wanted to have, and that was a barrier to working towards solutions. And I think more and more that with the push of universal screening, we're seeing a lot of innovative ways to do a better job on, when I think about the SBIRT stuff, that there's screening, the brief intervention, like most healthcare folks get into this field because we care about people and we want to improve outcomes for people. But the last part, the referral to successful treatment part, is, I think, sort of in my mind where the next frontier is. I think that across the state, universal screening is starting to happen in many more spaces. Some of those brief interventions and just compassionate responses are becoming more of the norm. And I think the next frontier is kind of this care coordination, referral to treatment, figuring out the connective tissue between the healthcare system and the community, and making sure that those two entities are communicating back and forth, and that that we're able to hold a pregnant person and a birthing person and a postpartum person all the way through that continuum. So some specifics that I'm aware of in terms of what that looks like. I'm part of a policy analysis work group with Illuminate Colorado, and we're in the process right now of trying to create some best practice guidance around toxicology testing. So this is kind of diving into the micro of, how do you know when you test? What do you do if there's a positive test? What is the reason behind the testing? And if everybody is doing that differently across the state, outcomes are going to look really different. Birthing people are going to have really different experiences. So one initiative is just trying to streamline and help hospitals create policies that are transparent so that patients are empowered to know what they're going into when they're walking into, the profound experience of giving birth, and that they know what to expect, and that they can, know the choices that are available to them and make the best choices for them and their families. So that is, in process right now. We're having meetings about it and working on that guidance. So that's one example of something that's going on. And then I also think just seeing expansion of treatment services. I love integrated care, and I think everybody on this panel in some way, shape, or form is involved in integrated care, and sort of the not making those referrals to conceptualizing mental health as something that happens away from an OBGYN setting, and actually bringing mental health services to less stigmatized places like healthcare settings where it's more normalized for everybody to go and receive care. So I also love the movement in Colorado toward more and more integrated care.
Thank you so much, Callan. I don't know if it's the poet in me on a Friday, but you guys are really great at sound bites. So I wrote down, can't solve a problem you're not willing to have, which I thought was really profound. You hit on something called the connective tissue, which was a part that we were hoping to get to in this panel. And I want to do the Q&A justice, so we're going to cut it off short, but maybe someone will raise it, about the fact that perinatal mental health is a really long time period from conception through first year postpartum. That can be, 12 months plus, 18 with pregnancy and beyond. and who really follows the parents throughout that whole time period and holds their care and manages care and coordinates care. And I know it's something that systems across Colorado are struggling with, figuring out where that connective tissue lives and how you pay for it. So certainly something that's on minds, and we will see if there's any questions, and if there isn't, maybe somebody can pick up on that connective tissue question in the meantime. I'm going to head to the chat and see what's going on.
Rebecca, I haven't seen any Q&A come in yet, so I think we can definitely discuss that. That would be great.
All right, who wants to take that one? It's not an easy question.
Jen?
Okay. Go for it.
Yeah, I'll jump in on that. As I mentioned, over at PSL and Rocky Mountain Hospital for Children, we have the navigation program. And although its official mission is more focused on navigating the families through their various medical challenges, really, a lot of that role is also an emotional support piece, and getting them connected with social work or housing programs or some other kind of financial supports as well. And so the more time I spend working there, the more I think that every, birthing parent, family, everyone who's entering, not even before, you mentioned the perinatal period is, this period of 18 months or so. And I'd actually argue that it backs up even before then to the time at which, for families who are working towards becoming pregnant, that it really goes back to that time when they start intending to have children, in terms of that sort of preconceptive period, which might also include a fertility struggle that they have. So I feel like in my imaginary world, I would love to see every OB office having some kind of support navigator person who could connect women who are experiencing pregnancy loss or fertility issues, or just questions about how do I get healthy before I become pregnant? How do we navigate that whole journey from, even before pregnancy happens, and then continue to support them, in that between period, should they have, a second pregnancy and beyond. So that's my utopia OB world picture. I don't know if that's helpful.
I think that's what we all want, right? I mean, I think the navigation is just the key, because, they're that center that, if you think about the spokes on a wheel, right, that connects all of the different things. And we think about how complex our healthcare systems are overall, whether it's OB or cardiology or, orthopedics, oncology, right? I mean, I think everyone is realizing that navigation is really the key, because there's so much. It's not just this traditional where you see a patient and then that's it, you provide that medical care. It's so much more of a wraparound, comprehensive approach. And I think that navigation is really key. I mean, we think about just navigating your pregnancy and what classes do I need to take? And, when you have a normal, healthy pregnancy, and, I need lactation services, or what else do you have postpartum? I need pelvic floor, right? There's so many components. And then I think when you add in behavioral health and you add in substance misuse to those elements and how complex those can get, I mean, I agree that navigation is it's the key to all of this, of ensuring that connectivity.
Dr. McLaughlin, staying on that for a minute, as an OB, one of the things that's hard about perinatal health care and perinatal mental health care is the shift from a real focus on the woman during pregnancy to a real shift on the baby after delivery, and really shifting to the pediatric office as the main place of care. Can you talk about any, how you think about women transitioning between the OBs being the center of their world to a pediatrician, and what does that look like as far as your practice goes?
Yeah, good question. Well, for me personally, what I've started doing is implementing a 2-week postpartum visit to get all patients back in pretty quickly within 2 weeks. Sooner, certainly if they need be for a physiologic reason like blood pressure or psychosocial reasons, to get them in sooner. So an earlier connection point than the traditional 6 weeks. And then we have the 6 weeks as well. And we also keep it as a living sort of dialogue of, do we need to have more connection points as well? And thank goodness that large organizations like ACOG and SMFM and other institutions are beginning to advocate for this. That we don't think of it as a postpartum visit. We think of it as that transition to postpartum care that is ongoing. That's following up on things that are continuing, from the prenatal care period. And to echo what Dr. Harn-Adams said and Heather said as well, if you said, hey, Blake, if I could, give you one thing tomorrow that would, be the most beneficial thing I could give you professionally, it would be a integration person. It would be a nurse navigator, a care coordinator that could take on this role. I mean, I wouldn't ask for a piece of equipment. I wouldn't ask for more office space. I wouldn't, ask for a better ultrasound machine. I would ask for, a human being that can be that care coordinator, that nexus of care. And I think aligning with what Callan said, the future of where we're going, in terms of this as a culture and as a community, as a society, is we have to value and prioritize the pregnant person and what is having this sacred thing that's happening at this segment of their lives. We have to value it and elevate it and escalate it and give it the attention, the care that it needs, because it is really this sort of holy, sacred experience that these patients are going through that is completely transformative for their lives and for their families' lives. And it is this beautiful opportunity for us to intersect and interact in a way that's transformative. But to do it, it does take these individuals. So I think where we're going in the near future, and I'm hoping it's the next 3 to 5 years, is every single pregnant patient has a care coordinator, has a nurse navigator, someone like that's walking them through, that's shepherding them through this process. And so it is really leveraging this opportunity for the encounter.
Wow, you took us right to 2 o'clock, and I think said it so nicely that we probably couldn't have ended the panel on a better note. I just want to say thank you so much to all of you, to Callan, to Jill, and Jen, and Dr. McLaughlin and Heather, for taking the time. One of the things that's been so amazing to watch as an outsider is how much collaboration and willingness to support each other across Colorado systems exists and is continuing to grow. So thank you all so much. And thank you, CPCQC, for putting on this panel.
Thanks. Thanks, everyone. Greatly appreciated. And with that, with focus on behavioral health, we are going to head into our next 15-minute break and mindfulness. So feel free to join us and watch the video, or step away from your computer, turn off your video and just take a little break. And we'll see you back here at 2:15.